Welcome back to what I am sad to say is our last half hour. I'm Dr. Stephen Hodak, and I'm with Mark Pochapin. Hey, Mark. Mark is the chief of gastroenterology. He's the co-host of the show, and you're listening to Medical Grand Rounds on Dr. Radio, Sirius XM Channel 110. For the next 25 or 30 minutes, we'll continue this discussion about the thyroid, one of my favorite topics, with our expert, a true expert, Dr. Susan Mandel, who's a professor of medicine and radiology and the chief of the Division of Endocrinology, Diabetes, and Metabolism at the University of Pennsylvania Perelman School of Medicine. She gave our grand rounds today to our medical community, and now she is sharing her knowledge, her considerable knowledge, with all of our listeners. And that's what this show, Grand Rounds, is all about. And we want to ask you to join us if you're curious about the kinds of treatments available for thyroid nodules, medications that can be used for hyperthyroidism, an overactive thyroid, or hypothyroidism, an underactive thyroid. Give us a call, 1-877-NYU-DOCS. That's 1-877-698-3627, or email us your questions to docs@SiriusXM.com. Mark, we have Susan on the line. We have a bunch of callers who have been patiently waiting. Why don't we take some phone calls?
Let's go.
All right. So from New York, Barbara is next. Barbara, thanks for holding on the line. You're on Medical Grand Rounds. Go ahead, please.
Hi, thanks for taking my call.
Sure.
I'm calling because I had a thyroid nodule removed surgically 22 years ago. I had just had a baby, and I developed what I'm guessing is a goiter based on your description. And I've been on my levothyroxine ever since. Everything's been fine. And then my endocrinologist at Columbia, who I loved, who took care of me all those years, retired. And right when I got the letter he was retiring, I developed osteoporosis. And my thyroid numbers on my blood tests, which I have regularly, because I also have LCIS, went completely out of whack. So my primary care physician changed my dosage of levothyroxine because I was very high, and now I'm low. And he said just to stay on it for a few months and see how things go. But I'm wondering if that indicates I should be seeing another endocrinologist, or what you would recommend at this point.
Yeah, I bet your endocrinologist's name was Dr. McConnell, because I've wound up seeing a bunch of his patients in the last several months since he's retired. Barbara, can we ask your age?
58.
58. So at what age did you have your menopause?
51 when I had my ovaries removed.
So, and the reason I'm asking, and Susan will talk about this in a second, is that changing estrogen levels is one of the things that can cause a change in the need for thyroid hormone. There are a number of other factors. So maybe, Susan, you can jump in and talk about this a little bit more. What are the common reasons that we see that explain why patients may be very stable on a dose of thyroid hormone for years and then suddenly have a change? What are the common things that we talk to them about?
Sure. Barbara, first of all, I just want you to know I actually was a medical student and resident at Columbia many years ago, and Bob McConnell is like one of the people who influenced me to become an endocrinologist. So I'm so glad that he was your physician for so many years. So as Steve said, there's a number of things that can happen that can change someone's thyroid hormone requirements. And it's, something we have people who are on stable doses for, 5 or 6 years, and then all of a sudden something is off. So, there are a couple of things. One is, weight changes, and we sort of I'm just going to go down a whole list. We know that through the menopause, many studies have shown that the average female can gain somewhere between 5 to 7 pounds during the menopause transition. Usually that's not enough to change thyroid dose requirement. Usually you need, the weight has to change by more like 10 to 15 pounds. But that's something we'll always ask about. The other things we'll ask about are timing of taking the pill. So although thyroid hormone is really well absorbed, some studies have shown that it's better absorbed if you take it at night than if you take it in the morning. So if someone has switched from taking it in the morning to taking it at night, you might see that there's more thyroid hormone in the blood versus the other way around. So we'll ask about consistency in taking the medication. And then there's a number of medications that can either alter metabolism or interfere with the absorption of thyroid hormone. And so Steve mentioned estrogen. That's one that has to do with the metabolism. So if someone starts hormone therapy after menopause, there's less of a change if you use the patch than if you do oral estrogen. but that can lead to needing to take more thyroid hormone. It's not because of an absorption issue. You can take the estrogen pill with the thyroid hormone. It has to do with how thyroid hormone is metabolized within the body. If you heard that you have osteoporosis and you started to take a calcium supplement, and you're taking your calcium supplement or you're taking a multivitamin with calcium within 4 hours of taking your thyroid hormone, the calcium or iron in a multivitamin can interfere with thyroid hormone absorption. And then you need to take more thyroid hormone. The best thing is to separate your thyroid hormone from either a calcium supplement or a multivitamin containing calcium or an iron supplement. If through menopause you're having hot flashes, and you might have read that taking soy has some isoflavones that might help with hot flashes, it turns out that soy protein can interfere with the measurement of thyroid hormone. So if all of a sudden you're taking your thyroid hormone in the morning and now you're putting soy milk in your coffee or you're drinking some soy milk, that may require you to take more thyroid hormone. So the big things that interfere with absorption are soy protein, calcium supplements, not cow's milk, calcium supplements, and iron supplements. And then estrogen can change metabolism. There's something else that's important that can cause, it doesn't really change your thyroid hormone, but it causes the blood test to look kind of funny. So some women will notice some hair thinning at menopause, and they start to take biotin because biotin can potentially help with skin and hair changes. And if you take large amounts of biotin, it actually messes up how the blood tests measure thyroid hormone. So it can look like you're taking too much thyroid hormone, even though you're not. And then lastly, we have Mark on the phone, who's a gastroenterologist. I don't know if your thyroid was underactive because of the surgery, or if you developed Hashimoto's, which is an autoimmune thyroid disease and causes your thyroid to not work. But if it's the second one, which is autoimmune, you may also develop eventually other autoimmune diseases, which are not very serious, but one of them people have heard about is celiac disease. People sort of know it because that's the one where you can't have gluten. But if you develop celiac disease, that can be a reason it interferes with the absorption of thyroid hormone. So there's a number of things that we go down when we're trying to understand why someone who's been on a stable dose of levothyroxine, the dose has changed. And actually the last one might actually be the preparation itself. So if you've been on one brand and you go to another brand, or one generic and you go to another generic, sometimes there are differences in absorption. Even if it says 100 on it, you might absorb it a little differently. So there's sort of a list that we go down. And I have to tell you, honestly, sometimes I go down that whole list and I can't find a reason. And sometimes I just have to change the dose and then recheck in 6 weeks to make sure that, I've corrected the thyroid hormone levels.
Susan, I'm so glad you brought up the biotin issue, because this seems to be an endemic, an epidemic kind of fad supplement that people are using right now. And for so long, people didn't realize the degree to which this can affect not just thyroid tests, but if you look on some of the websites for the laboratory companies, there are literally pages of various kinds of tests for all different kinds of organ systems that can be affected by biotin. I think this is a big problem. And before people start using biotin or supplements that contain high doses of biotin, they have to really be aware that this can make them look like they have a disease that they don't have.
Yep, absolutely. And it does seem to be with big doses. One of the things that we've realized recently is that many prenatal vitamins have 30 to 50 micrograms and up to 300 micrograms of biotin. And it doesn't seem like that interferes. It really has to be in the 2,000 to 5,000 microgram range.
Right, which is typically the dose that people take when they're trying to supplement in a way that improves their hair growth, right? I'm not so sure it's fabulous for your hair anyway. So that's maybe a different discussion. But Barbara, thanks for that call. Thanks for sharing your story. Let's go to Massachusetts next and talk to Lindsay, I think, is on the phone from Massachusetts. Lindsay, go ahead, please.
Hi, thanks for taking my call. So I'm calling because I am 27, and in September I was diagnosed with subclinical hyperthyroid. I had no symptoms. My TSH at that time was 0.5. Since seeing an endocrinologist and had some follow-up, my levels have continued to decrease, but still no symptoms. All my other lab work was normal, ultrasound was normal. and I'm now 9 weeks pregnant. I had my TSH drawn 2 weeks ago, and it was 0.23. So I'm seeing my endocrinologist tomorrow, and I'm wondering what questions I should ask, what treatment plan I should expect, and if there's any treatment that would differ in pregnancy.
Yeah, so Susan is the perfect person to ask about this. So Susan, tell us first of all, what is subclinical hyperthyroidism? And then I'm sure you'll be able to talk extensively about the importance of thyroid function during normal pregnancy.
So first, Lindsay, congratulations. That's
yeah, congratulations. Yeah.
Congratulations, that's fantastic. So subclinical hyperthyroidism refers to the fact that it refers to something that we measure on blood tests. So I think we should take a step back and talk about blood tests because not everyone may know what a TSH is. Lindsay talked about TSH levels. So TSH stands for thyroid stimulating hormone. And thyroid stimulating hormone is not made in the thyroid. It is something that stimulates the thyroid to make thyroid hormone. Thyroid stimulating hormone is made in the pituitary gland. So the pituitary gland is like right behind your nose, between your eyes. And that's our master gland that makes lots of things that control, if you're female, it controls estrogen and how you ovulate. If you're male, it can control your testosterone production, it controls your adrenal glands, and it controls your thyroid. So the pituitary gland makes TSH that stimulates the thyroid to make thyroid hormone. The thyroid hormone makes two thyroid hormones, T4 called thyroxine. That's what you take when you take levothyroxine pills. The brands could be Synthroid or Levoxyl. The generic is levothyroxine. That's all T4, which has 4 iodines. The thyroid also makes a little bit of T3, which has 3 iodines. A lot of T3 is actually not made in the thyroid. It's made elsewhere in the body. But the thyroid only produces thyroid hormone if TSH is around to tell the thyroid to make thyroid hormone. So there always has to be a little bit of TSH in the blood so that the thyroid makes thyroid hormone every day. If for some reason the thyroid makes too little thyroid hormone, so some of our callers had underactive thyroids, if the thyroid levels drop, T4 and T3 levels drop, the pituitary tries to stimulate the thyroid to make more thyroid hormone and the TSH level rises. So a high TSH indicates that there's too little thyroid hormone in the blood, and the pituitary is trying to stimulate the thyroid to make more thyroid hormone. On the other hand, in hyperthyroidism, which is too much thyroid hormone, the pituitary gland senses there's too much T4 and T3 in the blood, and it decreases the production of TSH. It tries to unstimulate the thyroid by lowering the production of TSH. So subclinical hyperthyroidism refers to someone where the TSH is just a little bit below normal. So the pituitary is sensing there might be too much thyroid hormone in the blood, but the thyroid levels are still in the normal range, because it turns out that everybody kind of has their own little set point of where their thyroid hormone level should be. But it refers to the fact that you as a patient, your pituitary gland is sensing that whatever the concentrations are of T4 and T3 in your blood, it might be too much for where your particular set point is. And so the pituitary is trying to unstimulate the thyroid. The TSH is low, but still measurable, but the thyroid levels are not high. They're in the normal range, but they might be higher than where they should be for you. So Lindsay, most labs have as the normal range for TSH 0.35 or 0.4 to about 4.5 to 5. 0.5 in many labs is in the normal range. I don't know what the cutoff was here, but I suspect your TSH was just at that part where maybe it was a little bit lower. Your pituitary might have been trying to unstimulate. And that's why they were a little bit concerned. I think it always comes back to the definition of normal range. A normal range is where, about 96 to 97% of a quote normal population should be, which means there's a couple of people who are really normal, who are just right at the borders. And it could be that's where you are. You had a normal ultrasound, and your thyroid levels, it sounds like, were pretty stable. So whether you are normal when you're not, your thyroid levels are normal when you're not pregnant, but you're just at one end of normal, that may be just where you live. Pregnancy is a different time. So during pregnancy, what happens is HCG, which is the pregnancy hormone, which is how they confirmed your pregnancy, HCG levels go up. And it turns out that HCG is a protein that looks really similar to TSH. So what can happen is those high HCG levels that you have, especially at 9 weeks to 12 weeks of gestation, those high HCG levels can function like TSH or thyroid stimulating hormone. And what they can do is they bind to the thyroid gland and they tell the thyroid to make a little bit of extra thyroid hormone. And then your pituitary senses that and goes, oh, there's too much thyroid hormone. I need to unstimulate the thyroid so the TSH level goes down. Like your TSH level dropped to 0.23. That is totally normal for the end of the first trimester of pregnancy. In fact, it's been shown that up to 25% of women at the end of the first trimester of pregnancy have TSH levels that are even as low as 0.05, which is 5 times lower than yours. So where your TSH is now at 9 weeks is actually very indicative of a very healthy pregnancy, where your pregnancy hormone is doing exactly what it's supposed to do.
So it sounds like you're in good shape, Lindsay, and congratulations again. You still there with us, Lindsay?
Yes, I am. Thank you so much for the advice.
Yep, you're very welcome.
Oh,
Thanks
don't
for following.
forget to say, wait, Lindsay, oh, that's right. You're not taking thyroid hormone. Forget it. I was about to, for people who are pregnant and who are taking thyroid hormone, Lindsay, which is not you. We were just talking to somebody about thyroid hormone. So not for you, but for any of the callers who are pregnant and are taking thyroid hormone because their thyroid isn't working and are taking a prenatal vitamin, please don't forget to separate your thyroid hormone from your prenatal vitamin so that you don't have any interference of the absorption of thyroid hormone. Lindsay, that does not apply to you because you are not taking thyroid hormone.
Susan, talk a little bit about what happens when women are taking thyroid hormone and they do get pregnant and they don't have a thyroid or they don't have a functioning thyroid gland. They'll often need more thyroid hormone. How do we deal with that? Yeah, so really important. So in a normal pregnancy, when someone's thyroid is working correctly, it turns out that during pregnancy, your thyroid can make up to 30 to 40% more thyroid hormone during pregnancy. And that's really important. It has to do with the pregnancy itself and the changes that occur in pregnancy. The thyroid will increase its production of thyroid hormone. So that if your thyroid is not working at all because you've had surgery, or if your thyroid is not working or partially not working and you're taking thyroid hormone, it's important to remember that during pregnancy, since there's increased requirement for thyroid hormone, and if you're relying on a pill of levothyroxine to meet that requirement, that you will likely need to take more thyroid hormone, a larger dose during pregnancy. And what's really important is that this often occurs early in pregnancy. So Lindsay just said she was seeing her endocrinologist soon. I don't know when she saw her OB doctor, but many women in the United States who are pregnant don't see their OBs till around 10 to 12 weeks of pregnancy. And you can actually need more thyroid hormone as early as 5 to 6 weeks of pregnancy. So if you are taking thyroid hormone because your thyroid isn't working and you find out that you're pregnant, it's really important to either immediately call the doctor who's managing your thyroid hormone to check your blood tests and make the adjustment, or some recommendations are just to take 2 extra pills a week. So maybe on a Monday and a Thursday, take an extra pill, but still call your doctor until you can get your blood tests checked. So, Susan, I always tell my patients that as soon as you know that you're pregnant, we need to be the second person that knows, right? You tell your spouse and then you tell us, because we want to see you early in the pregnancy so we can take care of this. Pregnancy can be completely normal as long as we work with the patient, make sure they have the thyroid hormone that they need and their thyroid function is normal throughout the pregnancy. Let's keep going. We have how does this happen, Mark? We've run out of time so fast, and we have a good guest, a good topic. It's a great show. We're
also talking about your favorite organ in the whole body, Steve. So I think it's even moving quicker.
Right. But we still have some callers that I want to get to. We only have about 7 minutes left in the show, Susan. So let's see how many more we can talk to. Sharon from Ohio is next. Sharon, thanks for being patient and holding on the line. You're on Medical Grand Rounds. Go ahead, please. Sharon, are you with us?
Yes, I am. Hello.
Hello. Go ahead, Sharon. Welcome to the show.
Okay, the right Sharon, right?
Yes.
Okay. I am 79 years old. I've been on Synthroid, 88 grams, for about 25 years. My doctor, a different doctor, told me that she wants my thyroid at a lower, it's way too high the test. So she put me on 55 grams. She said it's still too high. So she lowered it to 70. What am I at? Wait, 55? No, now I'm on 55. I was on 75. Sorry. Okay. She said eventually I may be off Synthroid altogether. It's way too high according to her terms. Now, when I look on my chart on Cleveland Clinic is where it is, it says normal range, but she said, no, I don't like it. So, so I'm wondering, somebody said I should really go to an endocrinologist. I like my family doctor. She handles my other medicine. I don't know what to do. Is this something, and what are the symptoms of all this that I should be looking for?
That's a very important question. Susan, what would you tell Sharon?
So Sharon, these are always challenging. I would say it's really important to see what your blood tests are, but let's just talk a little bit about thyroid hormone requirements as someone gets older. So there are some studies that have shown that as people get to over 70 to 75, that they may need a little bit less thyroid hormone. That's actually been shown. So, if you were taking 112 or 125, you might need a little bit less. The dose that you were on, which was 88 and then 75 and then it's 50. It's actually a white pill that you're probably taking, which is 50. The nice thing for us when we prescribe thyroid hormone is that every strength is a different color. 88 is usually green, 75 is purple.
Okay,
and
Susan, now you're just showing off.
Yeah, right. That's just like you have to know this. People don't remember their colors, right, Steve?
Exactly.
So, it's hard to know without looking at your blood tests. It may be that you need a little bit less, but there are some other things that I'm thinking about because, may I ask, Sharon, I don't like to ask weight, but the reason why it's important is that people don't like to share their weights. But let me just give you an example, is that if you weighed, let's say, 150 pounds, 88 micrograms of thyroid hormone would be much less than you normally make a day. You might need to take 112 or 125. And for example, 50 micrograms of thyroid hormone is perhaps as much thyroid hormone as someone who weighs like 80 pounds would need if their thyroid wasn't working. So when I hear someone that's taking a small dose of thyroid hormone that's probably less than they would need based upon their body weight, and someone is saying that's still too much for you, I wonder if something else is going on in the thyroid. Like sometimes someone can have nodules in the thyroid that make too much thyroid hormone. So it's not quite clear to me, and maybe it is worth seeing an endocrinologist who can actually look at your blood tests and the pattern of your blood tests over time.
Yeah, Sharon, definitely an endocrinologist, and you have some good ones there at the Cleveland Clinic. And it doesn't mean you have to get rid of your general practice doctor. That person's going to be your family doctor for as long as you want them to be around. But an endocrinologist is a specialist and can probably help you out. Susan, we're running out of time. We have about 3 minutes left. Let's see if we can take one more quick call with a quick answer. Next from New Jersey, we have Maria. Maria, thanks for holding on the line. I'm sorry I have to rush you. We just are running out of time in the show. If you can ask your question quickly, we'll get you a quick response.
Oh, yeah. Thank you very much for taking my call. So I have a daughter. She was born with hypothyroidism. So since she's 8 days old, she's been taking Synthroid. So she's 17 right now. But for past 2 years, she's been her endocrinologist been adjusting her medication.
Yeah.
And then right now she's on 88. Now she's on 88, but she gained 20 pounds, like since dosage change. I'm afraid to mention it to her because she's so sensitive about her weight, as a teenager. But her blood work come out to be normal. I still take her to have a blood work every 3 months. Her blood work come out normal, so the doctor said, "Oh, just keep it 88." But since then, she had gained 20 pounds.
Maria, let me stop you there because we're running out of time. I just want Susan to be able to address your question. So Susan, when people gain weight, they may need more thyroid hormone. You talked about that earlier. Can you respond to Maria just a little bit?
Yeah, so Maria, like weight gain and weight loss, there's so many reasons for both of those, and certainly too much or too little thyroid can be involved. We're very fortunate that we have good blood tests, and so if the blood tests are in range, then we can remove the thyroid as one of the causes for the changes in weight. So it sounds like she's had stable doses a couple of times now on 88, so that's probably not then contributing to her weight changes. And so that this is the correct dose for her then, if that's what the endocrinologist is telling her.
Big problem that we've all been dealing with when everybody's gaining the COVID-19, right? Everybody's been gaining weight during the pandemic. Thyroid hormone doses are being changed left and right. And Susan, I don't know if you feel the same way, but I seem to be seeing a lot of weird thyroid tests that sort of mysteriously get better on their own just in the last year or so. And I wonder about issues related to the medication or the reagents that are used in the testing. It's been a constant frustration. It's something that I've been dealing with. A few other people have told me they feel that way as well. Something you're seeing also?
I see one test that's off, and if they have a history of being stable, I repeat it in a month and it tends to be fine. And I'm never sure if it's that someone skipped some pills, it's a reagent thing. I don't know the answer for it.
Yeah, we're about out of time. So I want to say thank you, Susan. This was a terrific show. And Mark, we had actually a great 2 hours. We talked about headaches in the first hour, so many callers. That's another very popular topic. We can't do this without our callers, and the questions are always so incredibly interesting. So thanks to Susan Mandel, thanks to Tom Burke in the first hour. Mark, thanks for attending Grand Rounds and telling us